Great, thank you. I'm Steve Hemelt from UNC, and this is joint work with Sarah Komisarow at Duke, and we can work well together across institutions. And we are bringing the spice to the potpourri session with quite a different topic. And we will hope to keep you engaged before lunch with tag teaming the presentation as well. So the topic is telemedicine in schools, and I hope by the end you'll see this as related to many of the themes we've talked about today. So brief motivation, there's been a lot of great work by people in this room, many other scholars, on short and long run influence of sort of traditional inputs into education. So you can think of that as smaller class sizes, spending per student, teacher quality, but clearly a student cannot benefit from the most phenomenal teacher if she's not in the room. And so we've also seen an increased attention to absence and attendance as a lever of importance when we think about education policy, both in academic work like the first citation, as well as sort of policy work around chronic absenteeism and other measures of presence in school. And so in this paper, we're looking at one form of health or healthcare access as a potential lever to influence presence in school. And there's been some great work around physical school-based health centers in schools, as well as funding for school counselors or mental health services. And so we enter that smaller literature with this paper. And so telemedicine, what is it? You should think about it in the ways listed here, but largely it augments the capacity of existing school staff. So it works on top of or with a school nurse to allow the kinds of services, or to allow services that aren't typically available to students. So acute primary preventative healthcare services, and it works through video conferencing and other technologies. So over the period we've studied, the technology has certainly evolved, and at present you can think of it as sort of a fancy iPad type system that the nurse or other provider in the school is using, and through that can access a physician or nurse practitioner who can prescribe, manage more complicated or somewhat emergent conditions, and is serving multiple schools at once. And that'll be an important facet for our study. And the why, policymakers, people interested in this mode of healthcare, talk about reduced costs in terms of dollars and time. So a parent needs to take a child to see a doctor, right? As well as the cost of accessing healthcare, to manage students' care within a school-based setting and the advantages that might come from that, such as reduced missed instructional time. And then it provides the capacity to reach hard to staff areas. And in North Carolina, the hard to staff area is over there on the west. So the rollout of these centers has been in western rural North Carolina. The 4 districts that are darkest shaded are our treatment districts, in which we are focused on elementary schools, in which telemedicine centers have been introduced. We have data over those 10 years with the rollout of these centers starting in 11-12. We're focused on elementary schools because they constitute the overwhelming majority of schools that have seen this program come to their schools. And we use 2 comparison groups. So we will exploit rollout over time, comparing differences within schools that saw a telemedicine center arrive relative to border districts who didn't, and then another set of health provider shortage areas in central and western North Carolina. And we'll talk a little bit more about what those are, but they reflect the healthcare needs in a way that the border districts do to some extent, but it's just to check on results. And we see similar patterns across those 2 comparison groups. So the rollout is over these years, you'll see a substantial share in the 2016 to 18 in terms of the number of elementary schools and enrolled students that we have in our study. And the sample, so the treatment districts are the first column, the border districts are the second, and then the couple health provider shortage areas are the third. And the health provider shortage areas can be defined in a number of ways, and we're still playing with alternate definitions of that group. There can be county-wide designations, population-specific designations. And so you'll see that that group looks a bit different than treatment and border. It is less white, more economically disadvantaged. And the treatment districts, just to give you a sense relative to the state of North Carolina, are much whiter, and they are more economically disadvantaged than the typical public school in North Carolina.
All right, so just to give you a little bit of a sense of where we're coming at this in terms of the healthcare environment in North Carolina, we only have one slide on this. What we've done is use data on the number of advanced practice providers per 10,000 residents, then partitioning all of 100 counties in North Carolina into these groups sort of based on their rurality. And what we see, a couple things in this graph, our treatment districts, which are the circles here, look a lot like other sort of rural and or what are called town, this sort of town classification, but they look a lot different than our city and suburban areas of North Carolina. We think what's striking about this in terms of healthcare providers, this here is physicians per 10,000 residents, but it looks similar for nurse practitioners. What we see is the difference in levels in terms of many fewer providers on a population basis in these more rural areas, and also lack of growth, which you can really see in urban parts of North Carolina following 2010. And so we think that, we're sort of entering this paper is sort of thinking about providing healthcare in schools in settings where healthcare providers are not widely accessible. So violating the equations and Greek letters, didn't know the rule.
That's not right.
So this paper, we take this difference in differences approach, looking at the introduction of school-based telemedicine centers in our treatment districts relative to these two comparison groups that Steve described before and after the introduction at the school level. So we'll show you some results from a couple of different variations on this difference in differences theme. And here's a picture just to add to the equation. So what we see prior to the beginning of the rollout of these school-based telemedicine centers in our 4 rural districts is that our treatment and control groups here, these are the border districts, look really similar in terms of what I'm showing here on this figure is chronic absenteeism, so rates of chronic absenteeism within schools. We see that our districts, treatment and control districts are trending quite similarly. And then following this vertical line, this is to the right of the vertical line would be the beginnings of the introduction of school-based telemedicine centers, which really ramps up considerably in 2014-15, and that's right the point at which we see sort of this crossing. So the raw data is very suggestive to us of this improvement in the share of students who are chronically absent across these two groups. So in our regression framework, panel A here is the number of days absent. Panel B is directly related to the figure, the likelihood that a student is chronically absent. We see really robust evidence of school-based telemedicine centers on these two absenteeism-related outcomes. So we see that SBTCs reduce the number of days absence by about 0.6 days per year. And perhaps more importantly, and perhaps more interestingly, for policy, we see this fairly substantial reduction in the likelihood that a student is chronically absent. And here we define chronically absent as missing, I believe, 18 days or 10% of the school year or more in a single year. We see this pretty robust 2 percentage point reduction, which is relative to this low-ish baseline of 6%, is about a 28% reduction. So perhaps surprising to us, one of the things we were very interested in was whether we could find any evidence of heterogeneous treatment effects across different student subgroups. And the answer is that we actually don't find a lot of evidence of this. So the benefits of school-based telemedicine centers are widely shared across groups. So blue versus orange here are 2 different control groups, and what you want to be looking at is the leftmost estimates are for all students, and then we have male versus female, economically disadvantaged versus non-economically disadvantaged, and then white, non-white is the sort of margin that we're looking, or partition of students that we're looking at here. And so in the paper, we actually try to assess the extent to which these subgroup effects differ statistically, and we actually don't find any evidence that they do. And this was perhaps a little bit surprising to us, but I think an important sort of finding nonetheless. So the things we do following these effects that we document on absenteeism-related outcomes, we're really interested in admittedly short-run effects on student achievement, just given the timing of the rollout of SBTCs. And we want to be sort of transparent here. We do find some weak evidence, I'd like to call it very weak, of negative short-run effects on test scores. And so what I mean by weak is that this finding is not robust to all specifications, control groups. It's actually sometimes differential across reading and math. But we want to sort of admit the possibility that that we do find these short-run negative impacts on student test scores. And so one of the things we did after finding this was try to better understand what was driving this. And so what we investigated was just the share of students in schools that were taking tests. And what we find is extraordinarily robust evidence of small increases, yet statistically significant, small increases in the share of students in schools, in treated schools, that are actually taking math and reading tests. And this is largely driven by increases in test taking among male and economically disadvantaged students. So we think sort of what's going on here, the story we'd like to tell, is that school-based telemedicine centers have these effects on absenteeism, and in some cases, and particularly potentially for chronically absent students, we think these might be sort of inducing changes in the testing pool through this broader reduction in absenteeism or increase in attendance. So that's sort of the story that we have in mind for what these centers are doing. The final thing we do in the paper, we examine whether the introduction of these school-based telemedicine centers have any discernible effects on student behavior, which we measure as disciplinary infractions. We look at violent and weapons-related infractions. This is following Sunny and John Holbein's work, this sort of classification. So violent and weapons-related infractions versus all others. We don't find actually any evidence that school-based telemedicine centers reduce these infractions, which we thought actually might be something that would happen. We also see no evidence of changes in the share of students who are diagnosed with disabilities, which we thought might be one sort of effect that school-based telemedicine could have in terms of providing healthcare access. So the key takeaways, we find these robust effects on absences, both on the number of days and also reductions in the likelihood of chronic absenteeism. These reductions are broadly shared across a number of student subgroups, but the sort of more complicated or nuanced message is that we do find some evidence of the potential for short-run decreases in academic achievement, which we think are likely driven by changes in the composition of tested students at our treated schools. So in terms of sort of where we see this paper going, we have our results here are admittedly somewhat short run given the timing of the scale up of these school-based telemedicine centers relative to when our data ends. So we might like to look at medium run or longer run outcomes in the future. We acknowledge, and I think this is actually important and policy relevant, that these are rural districts in the western part of the state that may not actually fully generalize to all schools in North Carolina, but may be policy relevant for settings where students face healthcare shortages, among other things. In terms of the next steps for this paper, we're very interested in thinking about how this intervention compares in terms of cost effectiveness to other perhaps education-related or education-oriented interventions that directly target absenteeism in schools. And we're also trying to explore ways that we might better get at these mechanisms or this underlying story that we have. We think the possibility of health data is limited and or non-existent, but we are trying to do work to try to think about exactly what underlies the results we found so far. Thanks.